Well, first of all, it's a pleasure and an honor to be invited and speak, participate in this kind of homage to Åke. And really, I got to know him most. My voice is a little bit raspy, but I got to know him best probably in this program that UNEP, and I think it was just UNEP, WHO really didn't have much to do with it except editing. We went for quite a while, meeting in Geneva, meeting here, et cetera, et cetera. But I did get to meet Åke once in his laboratory. And so this kind of shows, this is after fika, I think. So I have gotten to see him work. So first, the goal of this talk is to really talk about how the view of thyroid hormone action and thyroid disruption really is changing and how it's changing. And from my point of view, it's changed very slowly and too slowly and unnecessarily slowly, but we're getting there. I also put this picture of poison because I think we still think of toxins as poisons that kill us, not poisons that produce chronic disease, disorder, or developmental cognitive delays. And I think that this kind of universal image of a toxin might be changed. Not sure exactly how we would change that. I thought about different options that I decided not to put on. So the first thing is that a problem with adult thyroid disease is that the symptoms are kind of vague and ambiguous. And because of that, hormone levels in the blood are the sole predictor of thyroid disease. So this is kind of a classic image of the symptoms of thyroid disease that you can see here in hypothyroidism or hyperthyroidism, and many of these symptoms are kind of vague and ambiguous, and we have this idea that if you have too much thyroid hormone, you lose weight, for example. If you have too little, you gain weight. And there's some truth in that, but there's not a lot of truth in that. And so maybe a better way to think about this is just a long list of kind of vague things like confusion. There's one, lack of memory here. I'm sure we can all find ourselves in this list. And so maybe that's why thyroid hormone is so prescribed. But as a result of this kind of ambiguity in adults, the sole criterion for thyroid disease really is hormone levels in the blood. And one of the things that I think about a lot is this concept of a normal range. In this case, they've even got an optimal range. I would argue about TSH having a range like that. We can always have these kind of arguments. But the concept is that if your hormone levels are in this normal range, then if you've got a problem with forgetfulness or you're tired, well, it's not a thyroid problem, it's something else. So the logic of this comes from this kind of diagram here, where as long as thyroid hormone T4 and TSH is in this circle, you're normal. And if T4 levels, for example, if T4 levels are low but TSH is high, then you have hypothyroidism. If the opposite is true, you have hyperthyroidism. So these clinical definitions are based on hormone levels in the blood. It's actually a laboratory definition of a clinical syndrome, despite the fact that, in principle, you feel bad. That's why you went to the doctor in the first place. But if your hormone levels are normal, well, it's something else. So this tradition is that if you don't feel well, despite thyroid hormone replacement and normal TSH, then, well, it's some other problem. And the logic of this, the assumption is that is this kind of logic of homeostasis. And I'm sure everybody uses the term homeostasis. It's not that I don't like the term, I think it's used oftentimes without thinking about what it really means. So I don't like it. This concept of homeostasis and compensation, and in fact, when people have low thyroid hormone and TSH, clinicians also often refer to it as a compensatory increase in TSH. What is it compensating for? I don't really get that part. In the 2002 Global Assessment of Endocrine Disruptors, in the chapter that talks about the endocrine system, they described it kind of like a Walt Disney situation where you've got these cells that make a hormone that cause other cells to secrete another hormone, which then produces a negative feedback. And that this kind of produces this seesaw, that if you get an imbalance, you know, if hormone A declines, then B comes up to bring it back to normal. If B declines, then A comes up to bring it back to normal. And this is actually, in the 1970s, there were studies on thyroid hormone where they would take people and hook them up to an IV for 48 hours and measure thyroid hormone levels at 30-minute intervals. And this kind of variation was quite obvious, where TSH would be high, T4 would be low, and it would go back and forth. So this concept on a, let's say, circoral, an hourly basis is probably true. But what if at the baseline you have hormone level that's high and one that's low? You can't really call that compensation. And this is oftentimes what regulators will be confronted with, because there will be some change in hormone levels, but they're kind of arguing that, well, if TSH is elevated, then that's going to help the thyroid gland, etc. So this is one of the arguments that I like to make against that. Another thing is that, at least in the US, there's three primary treatments for hypothyroidism. This is T4 monotherapy, T4 and T3 combined therapy, and that's usually used when somebody is on T4 monotherapy but they don't feel good, so maybe if you give them a little T3 they'll feel better. Then there's desiccated thyroids, which is kind of an old-fashioned sort of approach. Now, the interesting part is that the American Thyroid Association did a survey of 12,000 patients with hypothyroidism, and it turned out that overall, out of 12,000 people, most people rated their satisfaction both with their therapy and with their physician 5 out of 10, which was embarrassing. And the people who were happiest were the ones on desiccated thyroid. Now, I've heard people come to different conclusions, that those people are crazy anyway, so they're going to be happy, that sort of thing. But I actually think we might be missing something. So I think that one of the kind of findings from our lab is that very few of the assumptions that I learned, and I'll say assumptions because it was given to me as fact, and then when I went to read the literature supporting that fact, there was no literature. So it was really an assumption about how thyroid hormone works and also how sensitive we are to thyroid hormone. One of the misconceptions is kind of resolved here, that shows that the intra-individual variation of thyroid hormone is about 10% of the inter-individual variation. So the population variance is huge, but my variance, I hope, is very small. So you and I can have thyroid hormone levels that never overlap, but it's normal for me and it's normal for you. Therefore, the biggest consequence of that to me in this field is that the relationship of interest between thyroid hormone levels in the reference range, in the population reference range, chemical exposures and outcome measures can't be ignored, these are going to be clinically relevant population measures that are really important to take into considerations. The number of times people have asked me if a chemical is associated with thyroid disease, with hypothyroidism or Graves' disease, and the first thing I say is that when most epidemiologists do these studies that have to do with thyroid hormone, they exclude people with overt thyroid disease. Therefore, you can't see if there's a relationship between exposure and disease. And then they come back and say, well, but can you say that this chemical is causing thyroid disease? And I say, no. The other kind of misconception has to do with the way we think about the way the system works. This is kind of a classic. You know, the bad part about this, I'm looking here and I can't see it because I don't have my glasses. If I put my glasses on, I still can't see it because they're reading glasses. So, so I'm making all this up. It could be saying something completely different. So the thing about the thyroid system is that the brain, the hypothalamus, controls the pituitary, which then controls the thyroid gland. Thyroid gland secretes hormones. These hormones exert a negative feedback effect, and some of these hormones go into tissue and does things, makes us feel good. And this is really a Walt Disney kind of model. It's very simple, and it simply doesn't work. So this is a little bit more complicated. This is taken from Mary Gilbert's recent review, and there's a couple of points here that I want to make. The first is, it is true that the hypothalamus secretes a hormone to stimulate the pituitary gland, which then stimulates the thyroid gland, but negative feedback is mediated by a very specific thyroid hormone receptor, the TR-beta 2 receptor, both in the hypothalamus and in the pituitary. And then thyroid hormone gains access to tissues through active transport. So the point here is that TSH is a biomarker of thyroid hormone action on the beta receptor, not the alpha receptor. If you have a chemical that hits the alpha receptor, you're going to totally miss it. And in fact, in humans with a genetic defect in the alpha receptor, they have perfectly normal thyroid hormone levels. They have other kinds of problems. They have symptoms that are severe, but it's invisible to the thyroid system because we're stuck on this idea that we can look at thyroid hormone T4 and TSH, and that tells us the whole story. It's clear that that's not the case. Second thing is that thyroid hormone delivery to cells is controlled in large part locally. So thyroid hormone itself is traveling through the blood, but it doesn't go anywhere if a tissue doesn't want it. So the tissue has to take it up actively, it's got to metabolize it, and got to prepare it for delivery to the receptor. As a result, it means that thyroid hormone levels in the blood don't necessarily correlate with thyroid hormone disruption in tissue like the developing brain. And we've seen that. You know, I kind of grew up in a very conventional thyroid cult, and it didn't, you know, I was very, you know, I was a believer until the first experiment I did with PCBs, and then that changed I became no longer a cult member. I had to leave the American Thyroid Association. I've never gone back. So the second point I want to make is, what does compensation mean? And I'm making a big point of this because the National Academy wrote a report that was published in 2005 that had to do with thyroid disease, or at least the effect of perchlorate. That part's not really that important, but they used the term compensation in a developing brain 35 times Now you can do that because it's a PDF and it's really simple to measure the number of times that they use that word. But there wasn't a single reference that they used for the 35 times that they made the comment that the developing human brain has a robust capacity for compensation. Now, to me, theoretically, this is what compensation means. As if this yellow line is T4, is thyroid hormone, as it goes down, TSH comes up. Okay, we know that that'll happen. This red line is something that thyroid hormone does. This period here where T4 is coming down and TSH is coming up is compensation, because whatever thyroid hormone is doing, it's being maintained until you get to some point where that compensatory mechanism is saturated, and then whatever thyroid hormone was doing was beginning to diminish. So if we're going to talk about compensation, we have to talk about downstream effects. We can't just talk about adaptive responses. Okay, does that make sense? So one of the experiments that we did, this was a really complicated paper that took us a long time to do, and I just want to talk about these figures at the very bottom. What this shows is that these animals were treated with different doses of a drug that causes thyroid hormone levels to decline kind of moderately in a very small way. And what we're finding is that a gene in the brain that we know is regulated by thyroid hormone, in fact, we're looking in single cells. So we can measure the expression of this gene in single cells in the brain. And we can't find a time when thyroid hormone levels are diminished that the expression of this gene is not also diminished. Now, this was actually important. It's not really important for this talk. There are two different kinds of cell types in the cortex as measured by this. MCT8 is a transporter for thyroid hormone. That was kind of interesting. But the point here is that if compensation occurs in the developing brain, it occurs before we can measure any thyroid hormone insufficiency. By the time we can measure a change in thyroid hormone, the compensatory mechanism is already saturated, which really means that if we insist that there's a compensatory mechanism, it's a belief system based on no data. So I think that this is really important. It means that the developing human brain and the developing rat brain is much more sensitive to thyroid hormone insufficiency, especially at specific times during development, than we ever thought. So this just kind of recapitulates what I was saying about compensation. And people that know me and like to push my buttons will usually use words like homeostasis and compensation and watch me go off. So, yeah, right. I gave you a hint. Yeah, I grew up in a big family, so I'm used to it. So the fourth kind of concept here is that chemical effects on this hypothalamic pituitary thyroid axis really has confirmed that we don't know what we thought we knew about the thyroid system. And I'm just going to show, here's another set of data that's I still find perplexing. And this is a collaboration that we had with Mary Gilbert again. This graph here shows two different animals treated two different ways. The black bars here, the animals were treated with propylthiouracil, which is a drug that causes thyroid hormone levels to come down. You can see how they come down here. These animals were treated with DE71, a mixture of polybrominated diphenyl ethers, and you can see that thyroid hormone levels declined here too. Down here is TSH, and TSH levels rose as T4 levels went down when the animals were treated with PTU. Here, TSH levels didn't change at all. Now this violates dogma. So, do you believe dogma or do you believe your data? Many people have actually reported this, so that wasn't new. The point that I'm making here, though, is that chemicals can act in ways that really defy our ability to understand exactly what's happening. And this is really what Athena, this project that Åke and I and others here are on, this is really what it's all about. Because if you see that thyroid hormone levels are declining, now I'm just going forward. I see. If you see that thyroid hormone levels are declining, if you're a regulator, the question is, so what? Is it an adverse effect? You have to be able to look downstream to make that determination. This is another example where we treated these animals with PCBs, polychlorinated biphenyls, and looked at the expression of a gene that's regulated by thyroid hormone. What we saw was T4 levels went down, but the expression of this gene went up, which suggested that some of those PCBs are acting like thyroid hormone. I didn't use in the paper when we published this, I didn't use the term agonist because to me that means something really specific, but it's producing an effect that's like thyroid hormone. Here again, this is the cerebellum. We could find that when you make the animals hypothyroid, this part of the cerebellum, now what's happening is these cells are being born out on the outside surface of the cerebellum and they migrate across into the internal zone. Hypothyroidism blocks that migration. PCBs partially restored that. So again, PCBs are acting somewhat like thyroid hormone here. One of the other, this took a long time, and this is kind of a compilation of a number of papers, but what this shows is that if you activate the gene that codes for CYP1A1, you get the metabolism of individual PCB congeners that can then bind to the receptor and activate gene expression. We even showed this in the human placenta that that the expression of this enzyme CYP1A1 is really tightly correlated, and these are actually feral people. They're not just, they're running wild, eating all kinds of stuff. I was really actually surprised at the level of correlation between CYP1A1 expression. These genes are regulated, known to be directly regulated by thyroid hormone in the placenta, and also are related to fetal growth. So I think, I don't know how I completely lost track of time. So I always worry because when I used to start to say something to my son, he would say, "No, don't start." So I'm always afraid that I've lost track completely. And I didn't inhale. So there were, in this population of pregnant women, there was a group of women who had no CYP1A1 expression that was measurable. And in those people, thyroid hormone itself in cord blood was correlated with the expression of these genes that are regulated by thyroid hormone. But in those women that had CYP1A1 expression, thyroid hormone was not correlated with the expression of those genes. Now, this is all correlational, and I can't say causation, but if there's a definition of endocrine disruption, it's the ability of a chemical to interfere with the ability of a hormone to do something. And to me, this is as close as I've gotten to show this in a human population. So overall, the point that I want to make is that thyroid hormone action is controlled in a manner that depends both on serum hormone levels, that's certainly important, but also on local regulatory events that we're not capturing both clinically as well as toxicologically. And we need biomarkers of thyroid hormone action in tissues, and we can get that in rodent models. I suspect we can also get it in humans with tissues like placenta. Also, believe it or not, this isn't even a joke, foreskin is another kind of model tissue that I think we could use. It's kind of a, there's a selective population that are going to donate that tissue, but despite that, I think that it would be something that we could collect. I tried to collect brain before, but I haven't been successful at that. Although you wouldn't recognize that looking at our voting record in the U.S. So first of all, this is really the compilation of an enormous amount of work from a lot of people. One of the people that I have to really point out is Mary Gilbert. I don't know how many people know Mary, but she's probably done more at the US EPA to kind of uncover the effect of modest thyroid hormone insufficiency in brain development than really anybody else in the world. The classic paradigm in thyroidology is to take the thyroid gland out. I mean, there's nothing subtle about that. So also, Stephanie Guerra did much of the work, and my technician of 20 years, Ruby Bansal, also, she was involved in all of this. And I agree with the concept that the people in the lab are doing all the work, and people like me get to go have jet lag somewhere. So thank you.